Thank you for joining us for what promises to be a really interesting and engaging discussion. This is MS Transformed, Harnessing Biology and Inflammation. And I am a physician, but I am not a neurologist. I'm an urgent care doc, so I'm going to be learning as much as many of you out there will be learning about MS and what has changed in the past decade and century and a half, I suppose. So let's start by introducing the panelists. We start here with Dr. Tim Coetzee, who's Chief Advocacy Services and Research Officer at the National Multiple Sclerosis Society. And he's been instrumental in partnering and collaborating with others to advance research and treatment for people with MS. To his left is Dr. Al Sandrock, who is Group Senior Vice President and Chief Medical Officer at Biogen. He's a neurologist who oversees clinical development, regulatory affairs, safety and benefit risk management, global clinical operations, and biometrics. Next to him is Dr. Howard Weiner, who many of you know. He's founder and director of the Partners Multiple Sclerosis Center, and he's the Robert L. Kroc Professor of Neurology at Harvard Medical School. He also is a neurologist who has spent more than 30 years in the research and clinical treatment of MS and has really been a pioneer for innovative new treatments. And to his left is Dr. Mike Panzara. He's Group Vice President and Therapeutic Area Head for Multiple Sclerosis and Neurology at Genzyme. He's a neurologist responsible for the clinical development strategy and oversight in MS and neurology, again, at Genzyme. So we got Genzyme and Biogen. We're going to have them dueling over here. So be ready for the fireworks. So I think probably most of us need kind of a lay of the land. Like, how far have we come in the past 150 years since MS was first described? And I think we're going to turn to Dr. Weiner to sort of give us an overview.
So anyway, thank you very much. It's great to be here. The fact of the matter is, as far as MS is concerned, we've come an enormous distance. When I look at all the neurologic diseases, I think MS is a success story. When I first started working on MS in the 70s, there was no MRI scan, there were no treatments for MS, there wasn't a clear understanding of the disease, and now we have a number of FDA-approved drugs. So when we talk about innovation or developing medicines going forward, what's needed, and I think we can take the example of MS. So number one, we need to understand mechanism, and I think Mike and I were talking about this last night at dinner. We now understand the role of T cells in multiple sclerosis and how you can affect that pattern. The other thing you need is a marker, a biomarker, and the MRI has been a breakthrough. The first drug approved for MS was approved because the FDA panel saw changes on the MRI. And once we had these in place, it was a matter of doing the clinical trials and having many people involved. One of the things I would say, I think sitting up here on the stage, we're part of partners, and I think that there are a lot of partners going on. You have the National MS Society, that's been the bedrock of MS research, did the first trial of interferons, got the money to do the first trial of interferons in MS. Then you have industry, Al and Mike, who actually came out of academics. Al was at the Mass General, Mike was at the Brigham with us, and it shows the intersection. Now there's a seamless interaction between industry and academics, and they've really been pioneers in developing the new therapies. So why are we doing so well in MS compared to not having drugs for Alzheimer's or ALS or whatever? One, we know mechanism. Two, we have targets that we can test. And number three, we have a measure, an outcome measure. What's ahead, and we'll talk about that, is going to be progressive MS, which drugs to use, and how to individualize patients. So that's the lay of the land, if you will.
So it's a happy story here in the world of MS. Let me ask each of you, other than Dr. Weiner, what makes you so optimistic about the future care of patients with MS? I'll start with you.
So I think, Howard really touched on a lot of it. Is you know, it's happy to a point in the sense that we have choices, you know, 12 therapies that are approved, you know, several symptomatic therapies. I think all, you know, really highlight that, you know, the person who's diagnosed with MS today, at least relapsing remitting MS, has choices that weren't existent 20 years ago. And so that's really a remarkable transformation in the field. I think, you know, what worries and what, you know, makes one cautious about this is, you know, there's the question the person with MS asks, and I'm sure Howard and Al and Mike got this, is I'm diagnosed with a relapsing remitting MS, when am I going to convert to secondary progressive MS? That weighs on people. Or if I'm living with progressive forms of the disease, they're like, you know, great, 12 choices for the other people, but what about me? So I think, you know, we have to balance the happiness and the optimism and the innovation with some real reality that for many people, even the choices we have today aren't perfect. And so I think continued work around mechanism is really going to be critical to making some change there.
Well, thanks, Mallika. I think for relapsing, you know, all these treatments are for relapsing forms of MS, so people who are still having inflammatory events in the brain. And as Tim is basically pointing out, we don't have good drugs for the progressive stage of MS, and that's a problem. But even in the relapsing stage, we have 9 or 10 drugs, and it's a bit trial and error in terms of what the patients have to go through. What we notice is that people tend to be switching around, and it can take years before they get to the right medicine. And this is probably what Howard was mentioning in terms of individualization. And it's a shame because the brain is being damaged until the optimal medicine is found. And as of right now, we don't have ways of repairing the brain. So these are young people who are having damage to the brain, and it can take a long time to get to the right therapy. So, and then part of it is that we can't measure how the disease is progressing very well, nor can we really measure whether or not the response to treatment is there. And so I think there's still an unmet need in relapsing MS, even if we have 9 or 10 drugs. And then, as Tim said, you know, once we get to the progressive stage, it's pretty bad for patients still. They progress, and we really don't have much.
Mike.
So I think, excuse me, I think much of this was alluded to, but I think one of the things that has really, there have been really 3 things, I think, that have transformed as you say, the happy story in MS, but at the same time have left a large segment of the MS population behind in terms of the development of therapeutics. Howard already alluded to it, was MRI imaging has transformed that, both in terms of being able to see, first of all, see that the disease is progressing, is changing, despite a normal outward appearance. That has changed the strategy on how we approach the disease, treating earlier and earlier, hoping to modify the outcome and prevent that onset of progressive disease because we haven't been successful. Second, it's allowed us to see early in the course of the disease whether our treatments impact or have the potential to impact the disease when we get to larger studies, phase 3. Thus, the biomarkers that we use, typically new enhancing lesions or new inflammatory lesions on MRI, have allowed us as drug developers to see early on with a small number of patients, does a therapeutic have potential in relapsing MS, and therefore and then learn that this has predictive value for later studies, thus de-risking a program early on and allowing us to then test the hypothesis of an effect and therefore move drugs quicker through the development process. Once that happened, you see a lot of players coming in, developing therapeutics, basing on this biomarker that then helps them decide whether their drugs are going to be going into later stage studies, and thus what you get is a large number of therapeutics. But what's missing here is that same link to progressive disease. There isn't a good biomarker where early on in trials you can assess an effect of a therapeutic that might be used in progressive disease or to treat disease progression and help de-risk that development and hopefully have a better predictive outcome. And this has led to lots of trial and error in the disease and a lot of great failures in treating progressive disease. So I think that is an important aspect that I think is still needs to be developed and will change once we get there, once we have those biomarkers that predict outcome, clinical outcome for disease progression. You're going to see that next revolution in drug development.
Dr. Weiner, do you think that you could sort of give us an idea of how the clinical course for a patient with MS has changed over the past 30 years? I understand that there's no typical MS patient, but what are we seeing in terms of how they are able to live their lives with some of these treatments that we'll get into a little bit later in recent decades?
So let me give some examples. Before we had any treatment, we saw patients, they would have attacks, they'd get better, they'd have attacks, they'd accumulate disability, and then they'd become progressive, and many of them would be disabled in a wheelchair. Now, when we see somebody, we immediately put them on therapy, and there's some patients that we put on therapy that are stabilized. And I had a young man say to me, well, now I'm cured. He says, I feel cured. And we had to treat him very aggressively. He was, had a lot of attacks. We actually gave him cyclophosphamide, then he went on an interferon. Now he's going on one of the Tecfidera, one of the oral medicines, and he's doing great. And he feels that he's been stabilized and his life is, there's another woman that I follow that we've done many of these things and it hasn't helped her and she's continued to progress. So what we see today in the clinic is early patients who are diagnosed that we put on therapy. We're able to help most of them, and they feel good. Some of them aren't helped, and we move to different types of medicine, and some of them enter the progressive stage. That's what it looks like.
Let's talk a little bit about what treatments are currently available for patients, especially with relapsing MS. Lemtrada, that was developed by Genzyme, Daclizumab, that was developed by Biogen. What have these drugs been able to offer patients?
So,
Mike?
well, starting with Lemtrada, I think Lemtrada offers something unique in terms of the approach to the disease. I mean, as was already alluded to by Howard, the lymphocyte has been known for a time to be a very important actor, bad actor, if you will, in multiple sclerosis. And Lemtrada has taken the development of Lemtrada and the history of Lemtrada is that of aggressively targeting the lymphocyte such that then leads to a change in the immune environment, if you will, following treatment, of a once-a-year treatment that leads to a change in the immune environment that then, for many patients, leads to immunomodulation that leads to persistent remissions. And that's a unique approach where you're trying to modify the immune system to lead to a long-term effect. So that is the promise that Lemtrada offers to many patients. And with that great benefit comes some risk, which also requires close monitoring. But the benefit risk in that setting where you have many patients who receive 2 courses of treatment and then do not need additional treatments is quite unique in terms of the approach. And it does tie back to that core biology, knowing that the lymphocyte is very important in the disease process. And if we can modify that as early as possible in the disease, you can have long-term benefit.
Given once a year?
Once a year for 2 courses of therapy, and for many patients, that's all they'll need. And of course, we're continuing to follow those patients for 5, 10 years, because what's going to be very important is when the biology of the disease and the pathophysiology of MS is so tightly linked to the lymphocyte, Lemtrada allows us to test the hypothesis is early in the disease you alter the immune response and alter the course of the disease with a therapy targeting that lymphocyte over 2 courses. How many of those people have you permanently modified the disease course? And as we follow patients for 5, 10 years, we're going to learn, is there a group of patients in permanent remission? And we're committed to continuing to follow because that's an important question.
Al, what about Biogen's Daclizumab?
Well, Daclizumab was just filed, and it hasn't been approved yet. I think there's 3 broad categories. I think of the therapeutic landscape into sort of 3 broad categories. You have the injectables, which were the first that were available, the interferons and Copaxone. They are very well tolerated. We know their safety, but the efficacy is, on average, on the modest side. Then you have the orals that came in a few years ago, and there's several now. And they sort of range from similar efficacy to the injectables to perhaps a little better on average. So they're kind of in the mid-range. And then you have the high efficacy drugs like Lemtrada and Tysabri, which are both intravenous drugs. And as you go up the efficacy, you actually get less and less safety. So it seems to be that the more you hit the immune system, you get much more efficacy, but the safety becomes, more of an issue. And so obviously we'd love to have both, great efficacy and great safety. And so I think, as I said earlier, how you choose among these therapies is sort of an issue now. I think what we're looking at now in phase 2, there's drugs like anti-lingo, which we just showed data from at the Academy of Neurology meeting last week, where we're actually seeing drugs that may affect the disease without having any effect on the immune system. So anti-lingo binds to a protein in the brain, and it actually improves remyelination. So it makes the oligodendrocyte precursor cells sort of wake up, where they seem to be arrested in this stage where they're not myelinating the nerve fibers, and then they start to myelinate. And what we saw in that trial was a speeding up of the nerve conduction in the optic nerve after optic neuritis, which is sort of like an MS inflammatory event. So I think this is where we might actually start to enter a new era where before it was very much T-cell or cell-mediated immunity focused, and we may be moving toward more brain targets.
Have you been able to see evidence on MRI of remyelinization of
Yeah, so
neurons?
it's very hard to image the optic nerve, so we measured speed of conduction. In the other trial that's going on right now, and that we'll see a readout on sort of early part of next year, is where we're going to actually look at the lesions with imaging, more advanced imaging technology, to see whether or not we see evidence of myelin being put back on. So we hope to see that.
That's great. Let's talk about some of the other new sort of experimental therapies out there. Can anyone speak about lemastine?
I guess I can, I'm up. So this is a drug that's used, it's an anti-allergy drug. It's FDA approved. It fell out of a screen that was developed by an innovator by the name of Jonah Chan at University of California, San Francisco, who basically was challenged by his department chair, Steve Hauser, who many know, to look at the libraries of existing approved drugs and see, is there anything out there that can promote myelin repair? And so he came up with a very innovative platform technology that showed that this particular agent stimulated oligodendrocytes in culture to develop new myelin. And so now they're actually testing this in people because this drug has already, it's been on the market. It's not used that much, but it has passed all the safety tests. And so now they're doing a phase 2 trial using the same kind of approach that was used in Lingo. I think what excites me about this strategy, whether or not clemastine works out, is this notion that there are agents, either new chemical entities, existing agents, that can be targeting the nerve regeneration, and also others that target neuroprotection. I think for people with MS, this gets at this notion that you could think about stopping the disease through an immune modulatory strategy, but then taking it to the next step to the restorative aspect of the disease. And I know Howard is coined to sort of the 3 cures to MS description, and this would be under the restore. And I think for many people who live with this disease, the idea that you could get something back that you've lost is incredibly hopeful. And as somebody who worked in the myelin field before joining the society, I mean, the notion that we'd be talking about trials for neurorestorative agents is pretty remarkable. I think 10 years ago, it was an idea, but the idea that we'd actually be talking about that now is, I think, speaks to where the science and the technology and the innovation is really coming together in a way that could be transformative for MS, but I think also other indications.
What about this notion of a nasal vaccine? Does anybody know about that?
So I can talk to that because I think I've developing that, whatever. So Tim mentioned in quotes the 3 cures. So a number of years ago, I wrote a book called Curing MS. And any doctor knows that when they see a patient, they come in and they say, well, doc, when will there be a cure? Okay, you always hear that. And so what I said to my patients, I said, well, how do you define a cure? What do you mean by a cure? And it became clear in the patient's mind, and then we'll get to the nasal vaccine, that there's 3 things people think of as a cure. Number 1 is that they get the disease, they're treated, and then they're stable. Nothing else happens to them. And I think we're curing some people now. And I think to get to that cure is going to be individualized therapy, and we may talk about that. As Al said, getting people on the right medicine. With the MS Society, we're doing something called a summit study, where we want to have like a Framingham heart study. I know Biogen's interested in this as well, where we do long-term follow-up on patients. And then we'll find out how many people we're curing, how many people not, and what are the markers. The second is to restore the nervous system, and Al talked about that. And that's where this nasal vaccine, this is something we've developed or we're working on in animals, in animal models of progressive disease, by giving nasal anti-CD3. And the Brigham has licensed this and are working on that. You can stop progressive disease in the animals, and it relates to IL-10 going in the brain, affecting oligodendrocytes, neurons. IL-10 is very protective. The other thing, and I don't know whether we'll get to it, all the patients ask about stem cells. Can we rebuild, et cetera? Well, now the moral issues related to stem cells don't exist anymore. You can make stem cells from a person's own blood. You don't even need to do a skin biopsy. And that's going to be a big question, the anti-lingo, other things. Can we rebuild? And then the last is prevention, a vaccine. And that, I think, and I know there were some questions that people will talk about that, relate to the gut, I think, and the gut immune system, where we think that vaccines developed that will target the gut could be given to people at risk. And we're looking at the gut microbiome. Many people are doing that, support from the MS Society. And that, I'm sure, came up here in the Innovation Conference about how does the gut play in all these diseases. But I think that's going to be very important in MS as well.
Does anyone have anything to add about the microbiome? Because that seems to be an area of interest in not only in neurological diseases, but food allergies and things like that.
So I think, my sense on it is that I view this as one of those areas that almost like the early days of immunology and MS, where there's, I think, a lot of opportunity in this, in both understanding the biology of it, how it crosses over multiple diseases. I think what remains to figure out is, scientifically, it's amazing. I think how you think about that as a therapeutic intervention that changes the trajectory of somebody's disease and how we test that and validate that. I think there's a lot of unknowns, but I think it is emblematic of why continuing to sustain, our investments in really discovering and understanding bacteria, bugs, and the role they play in our system is so critical. And it's the kind of work that really our government entities need to support, because it seems incredibly abstract. But now we're starting to see, I think, some of the payoff that people will benefit from. I think also for people with MS, it's interesting because one of the things we hear, I hear frequently is, so tell me what diet should I change? Should I be thinking about probiotics? Should I be trying these different things? I'm sure that these guys get it all the time when you see patients. And part of what we don't know is, well, what is the role of the microbiome, and is a probiotic strategy going to be useful? We actually don't know the answer to those questions at this point, but we need to begin to address them meaningfully.
So Mallika, I was thinking when I was listening to Mike and my colleagues that, in this conference we've been talking about a wide variety of neurologic diseases, and as you pointed out at the very beginning, MS, or Chris pointed out, MS has been a success story, and I'm wondering whether MS could show us the way for these other diseases. Mike pointed out how we began to use the MRI as a biomarker, so where we can tell whether a drug works in relapsing MS in phase 2. If we could do the same with Parkinson's and other diseases, that would be a huge plus. And so, so that's one thing. And by the way, the animal model approach, we actually don't use that much in MS. We do use it some. It's not completely ignored, but the fact that we can go right into humans early has been an advantage. The second thing is the repair. As Tim was pointing out, could we learn about how to repair the nervous system in MS, start with that, and branch out to other situations where we'd like to repair? And then finally, this concept of precision medicine or individualized therapy. With Howard, we're doing this thing with a Google Watch, where we can actually measure how people are doing every day. And then we're also developing methods to image people, perhaps right in the office, using smaller versions of MRI scans, so we can actually count how many lesions are forming, and then also look at how much the brain is shrinking, things like that. And so could it be that MS would lead the way on personalized or individualized therapy for other diseases? Now, for the other diseases, we need therapies first, but it could be that MS leads the way there.
I've gotten a few really good questions from the audience, and one of them you touched on, Al, and it's actually specifically for you. Are you investigating targeting lingo in stroke and related white matter disease?
We are looking at other traumatic situations. It turns out that anti-lingo can also improve the regeneration of nerve fibers. And for some reason in the central nervous system, nerve fibers don't grow very well, whereas if you cut peripheral nerve fibers, they will regrow. And it turns out that there are things in the central nervous system of higher order vertebrates that block axonal regeneration. And so you can imagine that there's a lot of situations, stroke, but also spinal cord injury, traumatic brain injury, where we see nerve fiber loss. And then obviously once you've regrown the nerve fibers, you want to put the myelin back on. And so those are the kinds of things we're thinking about.
Another good question from the audience. How do you decide for any given patient? We talked about right drug for the right patient at the right time. How do you decide for any given patient which of the 12 drugs you try first, second, and so on? Dr. Weiner?
So I think it depends. We talk about individualized medicine. It depends on the patient, okay? So the first thing you have to do, believe it or not, there's some patients that still don't want to go on therapy. I had one yesterday, and I said, do you want to be in a wheelchair? That type of thing. You have to scare them. So, by the way, I'll say one thing about the vaccine. In order to study the microbiome, you got to get stool samples. And patients don't like to hear about giving stool samples. So I tell my doctors, here's how you get the stool sample from the patient. You say to them, do you want to help us develop a vaccine for MS? And they say, oh yeah, that's a great idea. Then you say, well, could you give us a sample? So it depends on the individual patient. You have a responsibility to tell them there's a lot of drugs out there. So first of all, you find out whether they're needle phobic. Some people said, I hate needles. You find out, some people say, I want to take a drug that's been out there for 10 or 20 years. That's important. I want to take an oral medicine. Some people have depression, heart disease, other autoimmune diseases. So it's done on the individual patient. The other thing that I think is very important to tell the patient, the most important thing is to go on a medicine and then be followed very carefully. So that's...
and what does that mean, followed carefully? Is that an MRI every 6 months? Is that...
So yeah, in our CLIMB study, and what we've done is that when someone goes on a medicine, they get an MRI every 6 months to make sure everything is stable, and then they get an MRI every year, and a spine every 2 years.
Okay.
Yeah, and I think this illustrates, what Howard has described is, I think it illustrates both the pluses that we have of having many choices, and then the challenges of those choices, because when people with MS, there are a number that, as Howard alludes to, will say, I don't want to try any of these. I want to try, a probiotic strategy, other wellness-based strategies, which for some individuals work. But this kind of conversation about weighing benefit and risk is not a one-size-fits-all. It's a very individualized conversation, and depending on where people are on the spectrum of the disease really influences that. And it's particularly amplified also for those instances where parents have a child who's been diagnosed with the disease, and there, you're just sort of weighing, this kid is living with this disease, and it doesn't lend itself to a formula, which is, I think, one of the big challenges we face in healthcare today about sort of formulaic approaches to managing patients. And I think this is just a disease that does not lend itself to it. And I think as we think about other diseases like Alzheimer's and Parkinson's, when we get to the place of having disease-modifying therapies, the MS experience is actually going to be very informative as to how neurologists are going to have to think about managing the disease.
The other principle that MS has taught us is to treat early. And you know, we started with drugs for relapsing MS, and then we did trials in people who had clinically isolated syndrome, so people who had optic neuritis or something like that, that didn't have the diagnosis yet of MS. We found out that treating early, if anything, is actually even more effective. And then I think when you, and then now there are even people doing things in people with radiologically isolated syndrome. So these are people who have imaging abnormalities that haven't had their first clinical event yet. So we're taking it to the earliest stages. And if you think about Alzheimer's, as Tim was saying, you know, in Alzheimer's, we know that amyloid deposition starts 20 years perhaps before first symptoms. And why would you wait until symptoms begin? And it seems to be, I think it's going to be a general rule that in neurologic diseases, treating early is better. And MS is showing us the way again.
Yep. And building upon that, it's not just when you treat, but it's also how aggressive you are in the earliest stages of the disease. I mean, Howard is a pioneer in the area of really treating the immune system with as high an efficacy approach as possible, even in that early stage, hoping to alter the longer-term course of disease. So it's not just, yes, we've grown more and more, which it seems obvious. You want to treat a disease before the actual pathological consequences of that disease progress. It has taken 20 years in MS to sort of finally move in that direction. And now the question becomes, okay, now that we want to treat early, how hard do we treat? How effective are we? How forceful are we, if you will, at those earliest stages of disease to try and hopefully alter the long-term consequences? And one of the challenges with MS, the long-term consequences could be 20 years later. It could be effects on cognition that our tools we have in clinical practice are not very effective at measuring, and you may miss a long-term. And that's been one of the challenges of why it has taken so long for neurologists to begin to treat earlier and earlier in the disease and to begin to treat with more effective therapies. I mean, when I was in training, I mean, it was you hold off. MS is not that bad. You just hold off on treating with anything until it's needed. Now we realize that was the wrong approach. It was too late for many patients.
Oh yeah, go ahead.
And I'd add that I think what the other transformation is sort of the technology solutions that, you know, Alan and Howard were talking about, that I think part of the paradigm shift that's going to need to happen is the tools for more continuous monitoring, because I mean the care now is, you know, you get seen by a neurologist every 6 months or once a year, and you know, a lot of stuff happens in that. And I think that when we think about altering the trajectory of a disease, you know, people won't remember a month from now, well, you know, what happened. And I think when we think about, you know, changing regimens for individuals, being able to know and look back and say, okay, this is what happened, I think that's what we need in order to have more impact in MS, but also other neurological diseases, because this kind of idea that every 6 months or a year you get assessed to measure progress is just, first of all, it slows down clinical trials, in my opinion, but also I think the precision medicine that we all talk about only will come through that interface.
There have been a couple of questions about the pharmaceutical industry in particular, and cost of treatment, health insurance, whether companies sort of change formulations and sort of change, you know, which patients can be treated, and that hurts patients and drives up costs. Any comments on that?
Well, the cost of MS medicines is very high. So I think the principle of precision medicine applies here as well. I think we should start thinking about the value. So the drug may be a high price, but it's of no value if it's not helping the patient, obviously. And so I think that's one of the reasons why I'm excited about these precision medicine tools, where we can actually tell whether or not the patient's getting the benefit. And if they are, if you think about a young person with MS, and they're destined potentially to lose their jobs because of the cognitive decline that Mike talked about. the inability to take care of their families. I think then if the drug is working, then I think the cost turns out to be probably cost effective. But I think I'd like to change the conversation from purely about cost to value. And I think these precision medicine technologies that Tim was talking about may help us get there.
Yeah, not much to add, except really, again, to emphasize, we have to look at what a therapy brings in terms of its outcome, in terms of what it means, in terms of how it alters, the life of these patients, and how we measure that, how we assess that, and how we show an advantage is going to be very important. I think that is the promise of these therapeutics, and it is on us to demonstrate that and to show what they do bring, because it is about value and what you can bring to the lives of the patients that should drive.
And are they so costly because it takes that much to develop them and test them? And it's an expensive process?
The average cost, I think the Tufts Center says that it's about $1.2 billion to get a drug approved. And so it's not inexpensive. And so, yeah, we charge a lot of money. I hope that what we're doing with those revenues is going back and doing research and development and trying to find even better therapies. That's the hope.
I think, this is a really complex conversation, and I think to Al's point, I think it has to be broader than just identifying the price of a therapy and a particular focus on the innovators that are developing those, because there's a lot of actors in this. There's the payer community, there's government, there's also the investor community, where if not enough revenue is being generated, the innovators are being punished for that, which has happened recently. So I think we have to have a broader conversation about how do we have access and ensure that individuals actually have access to the treatments that they need. And to the degree that the price of a therapy at list price gets in the way, we have to have that conversation and understand the economic dynamics of it without pointing fingers. I think these kinds of conversations are easy to reduce to the finger pointing. But I think on balance, also, it's critical not to make price the line item. That individuals really do need to be able to have access and not have it be economically distorting on them. This is what we see, with constituents who contact us. And I think this is really a societal conversation that involves many of the actors. And again, touching on value, and not just the value to the patient, but also to the health economics. If an individual can keep working because they have access to a therapy, that has profound economic impact. And we actually haven't been able to quantify that very well, but it's a part of it that I think we need to assess.
We only have about 10 minutes left, so let's change gears a little bit and move from talking about pharma to wellness approaches. A lot of questions about diet and exercise and homeopathic therapies, and maybe Dr. Weiner or Tim, if you could.
So I think that these are very important. The patients have all these questions. We know that these wellness approaches isn't just to make you feel good or whatever. They can actually affect the brain, and it can affect cells in the brain. There's one cell that we've been studying, which I think is a very important cell going forward, is the microglial cell. And I think that in terms of imaging, we need to be able to image the microglial cell, and we need to target it. But so how does that relate to wellness? If you look at animals, in some of the studies that we've done, if you affect their diet in certain ways, you can affect microglial cells. If you exercise them, you can affect microglial cells. There's something called enhanced environment. If you take a mouse and put them in a regular cage, or take a mouse and put it in a cage with all these toys, they're playing with all these toys, their microglial cells change. So I think that this wellness is important both psychologically for the patient, but I think there's a science there, and we need to understand the science. The other problem is that you get kind of crazy things, all these crazy diets people go on, different gluten-free, et cetera, et cetera. So it's hard to tell the patient exactly what to do. So what do we recommend? We recommend a Mediterranean diet, that type of thing. We also mentioned vitamin D is very important. We think people should be on vitamin D. But I think, and Al was talking about these devices and everything, I think wellness is very important. What you eat, exercise, using your mind, having a positive attitude are all very important. I think we need to integrate that into a patient. Then I'd love for us to understand the science behind it, because there is a science behind it.
Yeah. I couldn't agree more. I think that the science piece of it is a significant gap for us. I mean, when my organization studies what are the conversations people with MS are having online through social media, the #1 topic is wellness, with ordered of diet, exercise, and then mood, and sort of and we know that one of the most dominant comorbidities in MS is depression, and so part of what we need to try to tackle is what's the science around the diet and what's the strategy, but also then begin to assess what are the interventions and where can we alter things. I mean, we also know, for example, from some of the recent work that obesity really can amplify what's going on in MS. And so thinking about some of those strategies and helping individuals manage that is going to be important, not only for them living their life, but we also know that changes that these kinds of dimensions of things such as smoking, obesity, et cetera, can also affect clinical trial outcomes. And thinking about how that affects what's happening in a clinical trial is also something that we actually don't know. But I think for many people who live with the disease, they look at it, and I've had numerous conversations. They're like, I'm going to stay on my treatment, but I also want to know what's the diet and the exercise regimen I need to take. And unfortunately, we don't really have enough studies to say, okay, this is what you should do. But the advice that Howard gives is exactly what we say. Live a healthy diet, exercise frequently, cut out things that can exacerbate the disease, and those can really make a big difference.
Because presumably having comorbidities like diabetes and hypertension and coronary disease can't help.
It doesn't help, and I'll let the official doctors actually respond to it, but I think that what we've seen from some meta-analyses that we funded is that these are complicating factors that affect what we see in the clinic, and actually can affect probably the effectiveness of the treatments people are on as well.
To bring Al and Mike into this conversation, this is another audience question. Would industry partners ever be interested in helping fund studies to test for synergy between wellness and their drugs?
I would say, sure. I mean, we've just heard all of the benefits, the potential benefits, and the need to understand the science behind wellness, and how our drugs may be part of that process is obviously important. No, we're very interested in understanding as much as possible about the drugs that we have. And then even looking at the next generation of drugs, like Howard alluded to the microglia as we develop. We have several things in the early pipeline that focus on the microglia and the innate immune system. How you image that, how you study that ties in very well with, again, some of the things that Howard was alluding to. So yeah, it would be very important for us to understand as much about the disease as possible, so we can target the next generation of drugs to be even more effective.
I was thinking about this lately. If we start to think about restoring the brain, and a lot of these pathways that we're working on now are pathways that are naturally occurring during development. And what we know about development is that the nervous system makes more neurons than it needs, makes more synapses than it needs, and there's a pruning process that happens during development. And one of the things that affects that pruning process is activity, neuronal activity. And so I've often wondered whether one of the ways to optimize therapy, these restorative therapies, will be to concurrently provide the right stimuli so that the nervous system is active in the way it needs to be. And I think we may be getting to a point where we're going to be looking at the synergy of those two things.
With just a few minutes left, I want each one of you going down the line to tell me what you expect to see 5 years from now in the field of MS, good or bad. When we have this forum in 2020, what will we be talking about?
Well, I guess I'm up.
Sure.
want to start with Mike? No, just kidding. No, what I would expect is, we'll have a few more, disease-modifying treatments for relapsing remitting MS. I anticipate we'll have more symptomatic treatments that will enhance, quality of life for people with MS. I expect that we'll have, more neurorestorative, neuroprotective agents in clinical trials. Whether or not any will be approved, I don't know, but we'll have them in clinical trials. And I also expect that we'll be talking about the advances that we're making in progressive MS, because I think that we're at this critical inflection point, and that hopefully we'll have some approved agents for progressive MS, but I expect we'll have some that are actually making meaningful progress towards treating that disease in clinical trial.
So I think that in 5 years, MS patients will be wearing a Google Watch, will be getting imaged on a regular basis, and before the patient even arrives at the doctor's office, the doctor will be armed with information about how the patient was doing in the 6 or 3 months between visits, how their brain imaging has changed over time, how the bodies responded to the medicine that they were on. And in fact, some of these things may actually trigger the patient visit. So the patient may be told to go visit the doctor because of some change that occurs. And then, and that will all lead to patients getting to the right medicine much earlier. And therefore, they'll be getting the most value for the medicine they're paying for. And then I think we'll also be starting to see people taking one of these optimized immunomodulatory therapies and adding to that something that works on the nervous system itself to either protect the nervous system or to repair the nervous system should some lesions still form. Even though they're on optimal therapy, there may still be some lesions that form, and so they'll be adding something on top of the immunomodulatory therapies to protect or repair the nervous system.
I just got a comment from the audience saying Apple Watch is much better.
Okay, well, okay, it might be an Apple Watch.
So,
Google, Apple, yes.
having
Howard.
been in this business for a long time, I can tell you 5 years goes by very quickly, and I really don't think we'll be there in 5 years. I always tell my patients in 5 years because it sounds okay, but I agree with everything that, no, I'm serious. I agree with everything that Alan, Tim has said. I think it's going to be 10 years. I think in 5 years we'll be on our road to that. We'll be developing it, but to really be doing it in the clinic, I think we have to have a little bit of a longer view. I agree with Al. Individualized medicine, devices, better imaging, knowing which drugs to give, and giving protective drugs at the beginning with anti-inflammatory drugs.
Mike.
And after the advantage of being last is now you have to think of something that wasn't already said. So one thing I can clearly say is that I'm terrible at predicting the future. And if I look back over the last 15 years or so, I can't even predict a year or a month basically in this business because you really never know what's going to happen. What I think we're going to be really talking about is we're going to be talking about something that we never could have predicted today we would be talking about. We don't know enough. We don't know what we don't know. And I think we're going to, 5 years from now, there'll be something new, there'll be something exciting. We'll be along the path of all the things we've talked about today, but we'll be surprised at ourselves for not knowing what we then know in 5 years.
3, 2, 1, looking at the clock. Thank you, gentlemen, for being here. Really good discussion.